Dumelang, good morning, everyone. Thank you, Sekabo, for that introduction, and thank you for the organizers today to allow this opportunity for me to talk about and reflect on the investment in innovation in HIV prevention, which will only be an investment in our future. I have no financial interest to declare. So I will summarize the slide by saying that clearly we are not really on track to meet our UNAIDS 2030 targets. The UNAIDS estimates that in 2024, almost 6 times as many girls than boys aged 15 to 19 years old were newly diagnosed with HIV in sub-Saharan Africa. In the USA, most new infections occurred in young bisexual and gay men, and also in other regions still, more boys than girls have been infected with HIV. So these differences speak to differences in risk behavior. So interventions for young people need to be tailored to specific regional dynamics. We know already that key populations are hardly reached, marginalized groups who are disproportionately affected by the epidemic. And why is this the case? So apart from the biological risks, the reasons are complex and intertwining. These include gender and social disparities, inequalities like poverty and sexual health stigma still. With regards to HIV prevention, perceptions of low parental support are associated with less interest by adolescents in taking up PrEP. Low condom use and the lack of comprehensive sexual education leaves young people without the tools to equip themselves to make better decisions about their sexual relationships. Adolescents may be reluctant to seek sexual and reproductive health services if parental consent is required, and the UN actually recommends that the age for this consent be 10 years. However, less than 10% of countries have adopted this. Fragile health systems, devastating funding cuts, and discriminatory healthcare practices all limit the access to health to young key pups. So specific to adolescent girls and young women, factors like gender-based violence, intergenerational sex, stigma and discrimination still from families and at clinics, and unequal power dynamics are added to the mix. So the global upsurge in anti-LGBT laws recently across the world have really hindered the HIV epidemic response. Same-sex relationships are outlawed in at least 30 African countries, but still in places where it is legal, like South Africa, it's not necessarily safe to be queer because of our other epidemic, which is sexual violence against women and queer people. Transgender people, transgender women specifically, are at one of the most vulnerable groups for HIV, and those who practice sex work are at an even higher risk. As long as sex workers are criminalized, there will be a stigmatized community vulnerable to HIV. HIV prevalence in sex workers in South Africa, but this is all data, this is from 2019, estimates this prevalence to be 60%, and we have even less data in young sex workers who are at a higher risk for HIV because of using less access to health-related services, as well as having older clients. We heard yesterday about the 12-year-old sex worker who was failed by the government, failed by society, did not receive any social support when she became pregnant. So once again, we don't have good estimates of the HIV prevalence in young people who inject drugs. And we know that they are less likely to access services and know about safe injecting practices and HIV prevention. A global review of studies found that young people, especially young women, were at a much higher risk of HIV and hepatitis C, and this same study found that women were less likely to come forward as injecting drug users. Many West African countries, for example, Ghana, have now become transit hubs for heroin, and there is growing local demand for the drug in the country. The study also found that people start injecting drugs between the ages of 20 and 22, and often within a year of using drugs, they become HIV infected. I learned yesterday from a colleague that in Uganda, Alice, hi, that in Uganda, this age of people injecting drugs can actually be as young as 14 years old. In South Africa, there's a practice called Bluetoothing that some people do, which is voluntary injecting the blood from someone who has recently or just injected heroin in order to get less potent, cheaper secondary high. So oral PrEP has enjoyed a steady rollout in many countries, especially sub-Saharan Africa. But I do want to point out the sobering fact that in the last 2 years, PEPFAR-funded initiations contributed to over 90% worldwide. So young K-pops and PrEP. Lower self-perceived risk for getting HIV, misinformation about PrEP, and the requirement to actually be more than 35 kilograms to start oral PrEP are factors that contribute to young K-pops not wanting and not being able to access PrEP. Persistence on PrEP is met with its other challenges. For example, partner mistrust, school and work schedules, side effects, and adherence to the drug. Along our PrEP journey, we have gone from HIV testing, knowing your status, short-acting daily pills, and now there's a giant demand for long-acting PrEP and the rollout thereof. We don't really know whether event-driven PrEP works for women, but recent modeling data shows that if the pill doses are adjusted, it may be effective in preventing HIV, as it is with MSM and trans women. So MK8527 is a new drug which doesn't even have a name yet. It's a monthly PrEP pill, and it's part of the class called translocation inhibitors. Clinical trials are about to begin in 17 countries, and the DTHF is part of this. And we will be recruiting adolescent girls and young women and gender diverse populations over the age of 16. So if this is successful, we could have another prevention option for young K-pops. Another exciting multipurpose technology is the dual prevention pill, which combines oral PrEP and oral contraception. The two drugs are absorbed in the blood at roughly the same rate as they would be if they were given separately, and there haven't been any drug interactions with them. So this combination offers a nice discrete choice for women who want to prevent HIV and pregnancy. The pills don't look like Truvada, which is blue. Some potential drawbacks is that it cannot be used in breastfeeding women, but Viatris, which is a company that is making it, are working on a suitable pill. So there is also concern that there may be less demand for the DPP when long-acting injectables are rolled out. And also it will require significant coordination between the HIV prevention and family planning departments in the governments, which traditionally have been quite siloed. So the DAPI ring, so this contains an ARV called dapivirine, and it is user control. So a woman inserts it into the vagina, where it slowly releases dapivirine for 28 days. Then she can remove it, and she can reinsert a new one. So it's also safe in pregnant and breastfeeding women. It was approved back in 2016. It is available in some African countries. 2 studies were done that found that it is at least 35% effective overall, and even more effective if women use it more often and keep it in for longer. So we all know about cabotegravir, long-acting CAB as PrEP. So this is an injection given every 2 months into the buttocks, and has been, the 083 study was done in MSM and trans women, and our clinic was one of the sites, the only African site to do the study, and HPTN 084 was done in young women in sub-Saharan Africa. And CAB was found to be superior in efficacy and to Truvada, and safe and effective in pregnant and breastfeeding women as well. Cabotegravir was approved in South Africa in 2022, but we're still waiting for it to get to our public sector clinics. So lenacapavir, has been called a game changer, and the WHO now recommends it to be used as PrEP. So Len acts on different stages of HIV's life cycle to prevent HIV infection, and it has a high potency, which means it can be given less often. The Len injections are given every 6 months into the subcutaneous fatty tissue, usually in the abdomen, and when it is initiated, it has to be taken with 2 pills, Len pills, on the same day, then 2 pills a day after, and by day 3, it is fully active in preventing HIV. So there's also a 1-year version of Len, which is under investigation, and early results have been quite promising. So the program for Len HIV prevention studies is led by Gilead, and there are 4 purpose studies in this purpose tree, which look at safety, efficacy, acceptability, and in different groups, various populations around the world. So Purpose 1 and Purpose 2 are the studies that got everyone really excited last year about lenacapavir. P1 is done in adolescent girls and young women in Uganda and South Africa, and P2 is conducted worldwide in gender diverse populations and men who have sex with men. Participants were included if they were having condomless sex with cisgender men, and basically the studies enrolled a large number of people. In Purpose 1, there were 3 different groups into which people were randomized. Either they took the Len injection every 6 months, or they took the Truvada pill, or they took the Descovy, which is FTDF, or FTAF, which is similar to FTDF, but is smaller and has fewer side effects and has a better pharmacokinetic profile. We don't know, or before P1, we didn't really know how effective it was in preventing HIV in young women, or in women, cisgender women. So in P2, people were just divided up into either getting Len 6 monthly or the oral pill. So because the study was randomized and double-blinded, everybody took pills, everybody got 6 monthly injections, but depending on which group you were in, either your pills or your injection was placebo or dummy. So the results, which I'm sure you all know. So for P1, the interim study results found 0 HIV infections across all the study groups, and Len drug levels in adults and adolescents were quite similar. And there were quite a few pregnancies, over 100 births, which occurred equally across the groups. And spontaneous miscarriage outcomes were similar to what is expected in the general population. For Purpose 2, Len was 96% effective when compared with Truvada in preventing HIV. In the Len group, there were 2 people who seroconverted and became HIV positive, became infected with HIV. And when we look at the background of these people, both had biological in terms of STIs and the social risk factors for HIV. And this is especially highlights the importance of including young KPOPs early on in clinical research. So a brief summary of the results of the studies. Len was superior in efficacy to both of the oral PrEP agents, and the randomized phase of the study was stopped, and everybody is now receiving Len, and they will continue to receive Len until it is available in the clinics. Most of the side effects were injection site reactions, which are lumps and bumps, redness and pain where the injection is given. So when we explain to our participant the reason for the lumps is that the Len injection has to remain there in the tissue and slowly disperse, they were less anxious, but still some of them weren't really impressed with us because they could no longer wear crop tops. So that's an important thing. Both studies, both Purpose 1 and Purpose 2, included adolescents aged 16 to 17. To enroll adolescents, we had our ethics committee waive parental consent. Purpose 1 was the first HIV prevention clinical trial to allow pregnant and breastfeeding women to continue on the study drug, and Purpose 2 purposefully included gender diverse people of color to be enrolled. Advocates have been pushing for years for drug companies to include these complex populations in trials early on, and we need to acknowledge their tireless campaigning. So how should we invest in key pops? We need to ask them, firstly. So young trans and gender diverse people are at a significant risk of suicide, and it is known that providing gender-affirming hormone therapy can significantly improve their mental health outcomes. Last week, we started a trans health unit where we are providing comprehensive gender-affirming care and sexual health services, which we're very excited about. Comprehensive sexual education, which is rights-based, is really important, and access to that and ongoing engagement with peers and family is much needed. Yesterday's sessions also showed us how we should embrace innovations which are youth-designed approaches like digital platforms and MTV Sugar, and to ease communication around sexual health. So PrEP should be multidimensional. It should consider the details, the type of drug, the delivery, where it is received, where it is got, and the disposition, so the end user, their lifestyle, their preference, and their motivation for using PrEP. So the DTHF Fast PrEP study or implementation project aims to roll out and scale up PrEP in a sub-district in Cape Town to young key pops and their partners. It uses a hub and spokes approach using mobile clinics and youth-friendly clinics and schools, and a courier service to deliver PrEP and CAB. Dipirine, Ring, and Truvada are what is on offer. The service is completely comprehensive and peer-driven, and our Fast PrEP team had some beautiful posters up yesterday, and I hope you got to see them, and they're sitting right here, and there are one or two scattered in the crowd if you'd like to learn more about that. So the Prepare to Choose is nested within the Fast PrEP study, and it was found that most likely people who are most likely to persist on PrEP are older youth, those who initiated at mobile clinics, those who were previously on oral PrEP, and CAB users. So this is quite a nice slide from AVAC showing the updated PrEP timeline, also implementation projects and approvals for various PrEP, which leads us to access and equity. So if LEN is approved through the EU Medicines for All pathway, we are going to see expedited submissions in low to middle income countries done by Gilead. And just a few updates. Well, I'm sure we all know that in July, the Global Fund signed agreements with Gilead to procure LEN in low to middle income countries. So this is the first time in history that HIV prevention products will be introduced in LMICs at the same time as in high income countries. We just hope that the rollout keeps to that. In September, a strategy backed by Unitaid and Gates for the development of generic LEN to be supplied in over 100 LMICs came to fruition, and Dr. Reddy's and Hetero pharma companies in India will be making LEN at a cost of $40 per person per year, and we can have a look at how that compares to Gilead. Well done. Yes. So if LEN is to achieve a transformational change in this epidemic, we need coordinated response from civil society, from donors, from government, and from the private sector as well. And we need rapid implementation, we need scale up, and we need priority populations and regions to be prioritized. And we need good financing plans, all the while engaging young key pops every step of the way. Thank you.